Easy question. Which of the following regarding principles of surgical drain use is incorrect? So we put surgical drains for various reasons in a operative setting. What is the principle? Which of these is incorrect? Open drains function by gravity dependent drainage. In a way, it's right. It is gravity also, and it is also on capillary action. But mainly it is gravity. That's why they have to be placed at a lower level. So the abdominal drains that you put, they work by gravity and some capillary effect. JP drain operates on the principle of active suction. It's a type of closed drainage system. This is true. So JP drain, Romovac drains, the ones we use in surgery, they have an inherent suction. I don't need to attach it to a suction machine. It has an inbuilt suction effect. So it's a closed drainage system with suction. Open drainage cannot have suction. Obviously, if it's open to the environment. How will you generate a suction? But yes, closed drainage do have suctions like the JP drain. Chest drains are connected to an underwater seal to prevent re-entry of air into pleural cavity. This is correct. Obviously, if it is exposed to the environment, when the person will breathe in, the air from the environment will go in the tube and thereby into the pleural space. So when it is underwater, that negative intrathoracic pressure will not be able to suck the air because there will be a one-way valve. Pigtail catheters are avoided in image-guided intra-abdominal collections due to risk of inadvertent removal. This is false. Pigtail catheters are commonly used. I am sure you have used pigtail catheters for amoebic liver abscess, pyogenic liver abscess, pelvic abscesses. So we use pigtail catheters routinely. There is a risk of inadvertent removal, but that is not a reason to avoid them. They are good for drainage of intra-abdominal collections. So option D here is incorrect. Another question on basic principles of drain. Which of the following regarding the removal of drains is incorrect? Drains placed for post-operative bleed control could be removed after 24 hours if there is no bleeding. This is correct. On what premise is this principle? What is the principle of this? Understand, bleeding post-op can be reactionary. We are putting drains for one reason, to identify reactionary bleed. Best example after thyroidectomy, reactionary bleed. This will normally manifest within 24 hours. All right, it will normally manifest within 24 hours. If there is no bleeding in the first 24 hours, reactionary bleed later is unlikely. Right. So after 24 hours, if the intent was for blood, you can remove it like a thyroidectomy drain. Very common. T-tube is placed. It's a special type of drain. It is placed in the CVD. It should be routinely removed on the 7th post-operative day. This is wrong. Now, there are two answers to this question. One is what we do in clinical practice. In clinical practice, we remove it on the 9th to 10th day. Okay, in clinical practice, it is 9th to 10th day. But if you want to go by the answer given in Bailey, what does Bailey say? Bailey clearly says it should be kept for 2 to 3 weeks because you want the T-tube tract to form well. So if both options are there, go for 2 to 3 weeks. Otherwise, 9 to 10 days, what we follow in clinical practice is also okay, especially if you are using a latex T-tube. A PVC T-tube you will keep for longer because the irritation is lesser, so it takes a longer time for the tract to form. During chest drain removal, this is an important point. A patient is instructed to perform a Valsalva, that is expiration against closed glottis, to prevent re-entry. Obviously, this is correct. I don't want that when the tube is being removed, he should not take a deep breath in while it is being removed. He can take a deep breath and hold it, or he should do Valsalva. Valsalva means exhale forcibly with a closed glottis. Basically, I want the thoracic pressure to be positive, not negative. If it is negative, he is inspiring and I am pulling the tube out. During the removal, some air can get sucked in because you understand when I'm removing it, there is no underwater seal. So at that point of time, he should not inspire. Either he holds his breath at the end of inspiration or best he performs Valsalva. So if any residual air was there, that also will get pushed out. Normally, 15 to 20% surgical drains at the most remain active after 1 week. This is correct. So drains lose their function over a period of time. Either they will get obliterated or they'll lose their suction, they'll get displaced. So normally drains are going to be put for a limited duration or the intent for which it was placed, right? So best answer here is option B. This is a yes and no question. I mean, this is a direct pick from Bailey. Either you know it or you don't. There is no guesswork in this. So quite a straightforward question. This is from a chapter in Bailey where they are asking you what summarizes the core principles of minimal access surgery. Okay, basically we're talking about laparoscopic surgery. What will tell you the core principles? Now, if you use your common sense, you know the first thing that you do in any laparoscopic surgery is insufflation. Only thing is you should know a little bit about these short forms. But the first thing is insufflation, pneumoperitoneum, Mary's needle or open technique, however you choose. So first step in any laparoscopy will be insufflation, generation of pneumoperitoneum. Then the next will be visualization. Means put your camera, telescope, see everything, assess. Then put the ports, so instrumentation. Then put your instruments and do whatever you have to do. That is intervention. So it is IVII. Then how you handle the tissue? Remove whatever specimen has to be removed. Be aware, be oriented, and do safely. This is called as in vitrios principles. Okay, in vitrios principles. So this is how any surgery is done in laparoscopy. You think of lap chole. First, you will put varies or you will put the trocar by open technique. Then you will put other trocars. You will put the camera. After that, you will do the surgery, put the instruments. Then you will remove the gallbladder after your critical view and everything is attained. Then you look for hemostasis and you close the ports. This is your basic stepwise approach for a cholecystectomy, which you can apply to any laparoscopic surgery. That is on which in vitros is based. This is a trick question. I mean, it's not, it is from a corner of Bailey. Not many of us get the opportunity to see these kind of procedures, but you should know about this for entrances. Which of the following regarding third space endoscopy is correct? Now, third space means what? Normally, you think third space means interstitial space, isn't it? No. Understand, first space are your body cavities. Any body cavity is going to be the first space. Second space is going to be intraluminal. Okay. Third space means what? Third space means submucosal, a plane that you have generated. So third space endoscopy implies going in the submucosal plane. When do I go in the submucosal plane? When I have to do a poem, this is true. So for poem, I go per oral, endoscopic, cut the mucosa, go in the submucosal plane, then do the myotomy. That is poem, it is third space. It will require a full thickness perforation is wrong. In fact, this should not happen. I don't want a full thickness perforation. Otherwise, it will become a notes procedure, where I'm going through the bowel into the GI, into the abdominal cavity, or going through some hollow organ into the abdominal cavity. That is notes. I don't want that to do. I don't want to do that. In fact, full thickness perforation has to be avoided. Submucosal tunneling is a key maneuver. Yes, it is. That's how you'll generate the third space, right? And these procedures, stir, G-poem, stir is basically a technique for removal of submucosal tumors, like a cyst or a leiomyoma. Leiomyomas can be removed by stir technique. G-poem is gastric poem for gastroparesis and gastric disorders, right? So these are some of the third space endoscopies that you should know about.